Okay, I'm gonna leave.
Dr. Hanna, you want to get started, Dr. Hanna?
Okay. Can you see the screen? Let's see.
Yes, we can.
Yes. Well, welcome, Dr. Hanna.
We went to see Paul.
Yes.
Dr. Hanna.
I gotta move the,
Go see. Oh, Mom.
So there are pirates among us?
Go see in Hall.
okay, I'll move the camera.
Go Seton Hall.
Seton Hall.
It's a
No,
great
no.
school.
I'm just setting up, sorry. So you can see the screen, right? Oops,
Yes, sir.
Yes, we can.
can't see myself, but that's all right. So I'm going to do a few introductory slides, but mainly focus on medications, I understand. And they switched us from Microsoft to Google Slides, so it's a little adjustment. Give me 1 second.
Don't you just hate that when they change things?
Because most of the times when they do change them, they've never used them. And they make changes that don't make it easier.
Hi, Donna. Nice to hear
Hi.
you.
Okay, here
Sorry
we
I'm
are.
late though.
Can you see on the screen says update on Parkinson's?
Yes.
Yeah, yes.
All right, so this is just me. I'll move along. This was just a couple recent publications in a book called Neurology Secrets, which a lot of residents and other physicians use. So there are a couple chapters on Parkinson's related conditions, and one on these Parkinson plus syndromes with a couple colleagues. Do you see the cursor?
Yes, sir.
Yes.
Is it excessively moving? Okay, so Parkinson's, as you know, is a chronic progressive neurodegenerative condition, and was first described by James Parkinson over 200 years ago now. They just had the bicentennial anniversary, and he called it the Essay on the Shaking Palsy. And there's felt to be approximately 1 million individuals with Parkinson's in the US. By reports, it seems to be the second most common neurodegenerative condition after Alzheimer's. This might be increased now, but at least 1% of the population over 65, and up to 10% are young onset. We call young onset before age 40. Oh, sorry, it's really a million, and it's expected to triple over the next 50 years or so, and slightly more common in men. Before we get into medicines, I was just going to talk about the DAT scan quickly. Still, Parkinson's is based on a clinical diagnosis, which means what we see based on the history and exam in the clinic, and based on certain signs and symptoms. I'm just mentioning quickly DAT scan. I'm not saying everyone should get one, but sometimes we use it or find it helpful in certain situations. So it's the first and only FDA-approved visual imaging agent, and it's a nuclear medicine test for adult patients with suspected Parkinsonian syndromes. So it can be helpful in certain situations. It could help differentiate essential tremor. So essential tremor is more of a familial or genetic condition where you have action tremor when you're eating and drinking, a lot of times head shaking, tremor in the hands, not really a rest tremor, without stiffness and rigidity and slowness of movement or gait difficulty. It's usually more of an isolated action tremor. So if you're really not sure, it can help in that situation. They're looking at dopamine density in the brain. As you know, with Parkinson's, we tend to lose the dopamine, which we'll talk about, and you get symptoms. Some medications can give you symptoms that look like Parkinson's, so it may help in that case. So I've had people on different psychiatric medicines, and when they had the DAT scan, it was normal, so it was felt that it's the medicine that was making them have the symptoms. It was not Parkinson's. Or if somebody has very early signs and symptoms, it could be helpful.
When you say helpful, you mean just in diagnosis?
In diagnosis, yes, I'm sorry.
Okay.
It doesn't tell you if it's regular Parkinson's disease. I hate to use the word regular, but your typical Parkinson's. As you know, there's Parkinson-like variants, such as dementia with Lewy bodies. That's a different category. Progressive supranuclear palsy, where people have trouble looking up and down and a lot of falling and balance difficulty early on, or cortical basal degeneration. Anyway, there's these other Parkinson-like syndromes we're not going to talk about today. But that scan can tell you. Someone's unmuted, if you don't mind. It doesn't tell you which of those Parkinson conditions. It just tells you your dopamine is a little decreased. So I'm just going to go through this quickly because it's not the topic today as such, but this is a normal DAT scan. Some of you may have had one. Again, it's not it can help in dopamine assessment. So this is normal with 2 commas. If decreased, it's considered abnormal. But it doesn't tell you how bad the condition.
No, not really. Why?
It's not something that you repeat down the road. But it can. But if it's abnormal, it helps confirm the diagnosis. Okay. This is just a maybe interesting slide I saw at a conference where they were suggesting maybe in Parkinson's there's increased inflammation. They didn't go into much detail, but there are cells that are activated when you have some inflammatory situation in the brain. So there was a little survey of patients. We don't know the dose, but they showed that people that regularly take things like ibuprofen, Motrin, non-aspirin type of non-steroidals. So things, again, ibuprofen, there might be a little reduction of Parkinson's risk. But again, no one knows for sure the dosing, but it's just kind of intriguing that maybe it's just leading to more studies on possible inflammation being involved in Parkinson's. But that's all I can say at the moment. Okay, so this is a slide which I thought might be of interest. It's showing what research is being done on different medications. So the pharmaceutical agents, including vaccines or mostly pills like oral medications. You can see in Alzheimer's, there's a lot of research, a lot of studies looking at new treatments, asthma, very popular, HIV. But Parkinson's is, way up there at least. I mean, this is a few-year-old study, but it's just saying that there's a lot of things in the pipeline that they're looking at, both immune-related like vaccines or other drugs. So some are looking at little small molecule treatments. They're looking at these chronic conditions with large patient populations, different things in the pipeline. So we're way ahead of stroke and other things, which is good. I mean, not good, but anyway, Parkinson's is getting a lot of attention. I know you might be saying, but nothing really new is coming on the market very much, but we're optimistic. There's a lot of excitement, more than in years past. So I think we're getting closer. This is not really, again, part of this talk so much, and it's kind of a whole another discussion, but just to let you know, there's a lot of interest in what's called alpha-synuclein. So in the nerve cells of the brain, you have this protein called alpha-synuclein. The problem is in Parkinson's, it kind of clumps together. So you get these molecules that kind of get sticky and interfere with how the nerve cells function and causes damage and injury to the nerve cells, so they die off. So you're losing dopamine cells, at least partly they feel, with this clumping and interference with how the nerve cell works, causing damage. So you can imagine there are a lot of studies looking at agents to either prevent the clumping of the protein or help clean it out. So kind of like a vacuum cleaner to kind of get rid of this clumping before it causes injury. They've even found like if a nerve cell, say, dies off and releases the clump, another nerve cell might take it up and start getting affected. So they're looking at all these different ways, either to prevent clumping, clean the clumping, or prevent other cells from absorbing the clumps, so to speak. So researchers believe clearing out the clumping will protect the brain cell from degradation caused by Parkinson's. So just without going into too much detail, these are immune-related treatments. And I think all this excitement with the vaccines for COVID hopefully will has proven that things can move quickly if there's an interest and need and money and so on. So just briefly to say, there's a lot of different companies that are developing these kind of antibodies, kind of like you see the COVID vaccine. But I'm sorry, COVID is a different mechanism, but they're looking at ways to kind of prevent these conditions from developing. It was kind of interesting. There's a natural substance called mannitol. It's a kind of sugar. We also use it in the ICU for critical care situations, but at least in test tubes, they showed that they could reduce some of this clumping of the alpha synuclein with mannitol. And they looked at fruit flies, which may or not correlate with humans, but it helped them restore normal movements and reduce this clumping by like 70%, also in mice. But now they're just starting trials in humans. So I'm just using these things to point out some of the research avenues. So shifting gears a little bit, any questions? Or we'll get to it at the end. So when I was in training, I trained in Texas with one of the foremost Parkinson experts. But at the time, the focus was mostly on the motor things. You know, motor means the tremor, slowness of movement, stiffness, walking, balance. But as you know, there are a lot of other things that are not movement related, but can cause as much, if not more, difficulty. So like anxiety or mood issues can be prominent. Loss of smell. So some of these are highlighted. Even 10 years before you get symptoms, some people start losing sense of smell way before. Constipation is very common. Depression, as you know. Pain, drops in blood pressure. Usually more down the road, some memory difficulties in a subset. Even, as you know, drooling, something called REM sleep disorder. Some of you may have that, where at night, we're supposed to be motionless during certain parts of sleep. People have these vivid dreams, somebody's chasing you or you're fighting, and instead of not moving, you actually react and start punching and fighting, as you well know, and can cause injury to the bed partner or falling out of bed. So having this there's a link where it can predispose you to Parkinson's, or people who have this years later can develop Parkinson's at a higher rate. So it could be a warning sign. And other things like fatigue, excess sweating, change in urination, etc. So the reason I bring this up, the more we learn about non-motor or early symptoms, hopefully when there's a treatment that's more effective down the road, you know, you can intervene early before a person gets other symptoms. And we'll talk about that. Just briefly, as you know, this is the midbrain. That's deep in your brain and the brainstem at the bottom of the brain, where it kind of looks like Mickey Mouse upside down with the ears. So what happens in this condition, you lose some of these dark pigmented cells, and you get what's called Lewy bodies. So Lewy body is like a pathologist looks at a slice of brain under the microscope and sees this thing, and they're like, it's a Lewy body. So it's an accumulation of a certain protein. And you can get that also with Lewy body dementia, it's called, which is a cousin of Parkinson's, where you have a lot of hallucinations, rapid dementia, and sometimes not so much tremor, and often doesn't respond to medication as much. Or if you use typical Parkinson medicine, you may trigger more hallucinations or seeing things. So as we mentioned, there's a certain, some of this lingo, I apologize, it's a little medicalese, but there's a part of the brain called a striatum. That's what we looked at on the DAT scan, the caudate and putamen. So if I go back real quick, that's what they're looking at here. It's a slice of your brain. It's called the caudate and the putamen down there. So you lose the dopamine. Usually at time of death, you may have lost 90% in people with Parkinson's. If you've only lost about 50%, you probably don't have symptoms. The thought is somewhere between 50 and 75. You have to lose about 50 to 70% of these dopamine production before you really show motor symptoms. And the severity of this dopamine loss mostly correlates with the slowness of Parkinson's. So the most helpful thing is the slowness. That's why in the clinic we do this tapping and things like that. That's more helpful than, I use the term helpful, that's more specific, more sensitive than stiffness or gait difficulty. So what are some of the risk factors for Parkinson's? Certainly as you get older, if you have an identical twin, for example, with early Parkinson's, probably a family history, there's more genes being found all the time. That's all, we won't get into gene discussions. And there could be some possible link with certain herbicides, pesticides, heavy metals, certain types of work, like manganese miners, so manganese exposure. But there's growing evidence with certain pesticides and herbicides. I mean, you're seeing things on the radio and TV with paraquat, I think. Smoking actually may have some benefit or protect you a little bit. Not to start smoking, but something in the cigarette paper, they think, some chemical might be the cause. Okay, instead of just droning on, any questions at this point? Or
Yeah, could you explain what hyperhidrosis is?
just a fancy word for excess sweating?
Thank you.
Okay.
What kind of Parkinson's do fruit flies get?
That's a good question. No, I was trying to come up with something, but did you have an answer?
No, it sounds like a joke.
Yeah, they end up having an addiction to apples and oranges. So this is kind of interesting slide that they show it at different conferences. So this is when you're 0, when you're born, to about age 90. And the thought is before, so here's the motor symptoms. So say somebody around the 50s, 60s, they start getting motor symptoms that we know. But the interesting thing is usually before that, you get these non-motor things we've discussed, like sleep problems, depression, smelling, etc. And probably before that, there might be some kind of inflammation going on. Again, it's not clear so far. Maybe some abnormality of the or clumping of the alpha synuclein and different stress in the brain, like oxygen, abnormal oxygen radicals and things. So the point is all these things are happening, maybe leading to inflammation before you even get symptoms of Parkinson's. So we're trying to figure out how to intervene, how to pick up somebody early who's going to get it, do something here and prevent the development. So shifting to treatment options. So as far as prevention, there's nothing that's been proven 100%, convincingly to prevent disease progression so far. There's been some interest in Azilect, maybe, which we'll talk about. An MAOB, it's an inhibitor of an enzyme. The main things, though, is still to treat the symptoms, whether through medication or surgically. Try to manage non-motor symptoms, and then what sometimes you read about on websites called restorative, things like stem cell transplants or factors that keep the nerve cells healthy, neurotrophic, they call it. All right. This is a little bit of a busy slide, but I'll just go through it quickly. So this is kind of a dopamine producing nerve cell in the brain. I thought it was kind of colorful little slide. And this is the next, so this is the nerve cell that releases certain chemicals, and this is the target, the receiver, so the receptor. So you have this chemical, like an amino acid called tyrosine, it makes L-dopa. And that's why when you give somebody carbidopa, levodopa, or L-dopa, you're actually basically replacing the dopamine that's low. So you're kind of going here, you're giving them dopa, which gets made into dopamine, gets packaged in these little packaged cells, and it gets released. You don't have to worry about all this. And so it gets released here. Now, when it's released, there are two enzymes, COMT and MAO, which degrade the dopamine. They kind of break it down and help it recycle. But the reason I bring this up is there's a couple classes of medicines that try to block this and allows more of the chemical to be sitting around here, if that makes sense. So if you block this, you're not losing this. It's getting to where it needs to go before it gets sucked up over here. So again, you're either replacing levodopa or trying to prevent it from getting removed quickly. So this COMT works. I won't get into too much detail. I guess that's enough detail for that. But COMT, there's a medicine called entacapone, which blocks this, and then MAO is like Azilect or Sledgeline, which some of you may be on. Here's another way to look at it briefly. You have dopamine in your blood, in your circulation, and you're trying to get it into the brain. So this is the brain. This is your blood. So you want more of it to get into here. So you don't want it to be consumed in the bloodstream. You want it to get through. So that's why you try to block certain things to help more get in here. So here I'd mentioned Selegiline or Azilect or Sagiline. It blocks this breakdown. There's another medicine some of you may know about called amantadine. It's been around for decades, more to prevent the flu or antivirus medication. But it also helps tremor, helps two main things, a lot of tremor or dyskinesia, if you have a lot of involuntary movement. So amantadine, it does increase dopamine availability. So it works in a little different way to increase dopamine. And then there's things that stimulate the target. So is this making sense? Either you replace the dopamine that's missing with levodopa, still the most effective, potent medicine we have. You try to keep more of it around so it doesn't get sucked up or taken away by blocking certain things. You either increase the dopamine floating around with things like amantadine, or you take things that stimulate the target. So you don't actually give dopamine to stimulate the target. You give these dopamine agonists, which are mimicking, they're not actual dopamine, but like man-made dopamine. And some of you may be familiar with ropinirole or Requip, pramipexole or Mirapex. This medicine isn't used that much. Or the Nupro patch, the patch that people wear. So all of those go here, not through all this. Okay, now it gets a little wordy. But just to go quickly, the carbidopa, levodopa, or we call it Sinemet, comes in different dose sizes. So the main medicine, the levodopa, is the bottom. This carbidopa on top is this to help it get into the brain. So the top number is just the ingredient that kind of prevents upset stomach and helps it get to the brain where it needs to go. But the levodopa is the main replacement of your dopamine. So as you know, it comes in different sizes. Many of you might be taking 25-100 or 25-250. There's a controlled release in two sizes. Most of us typically use the regular release during the daytime and maybe a controlled release at night. There's some who use controlled release in the daytime. There's different ways to do it. There's something called Parcopa. If there's great difficulty swallowing, it just melts in your mouth. And there's a newer agent called Rytari, which is the same ingredient, but the purpose of it is to try to take it just 3 times a day. So say somebody is taking carbidopa 6, 7, 8 times a day, and it only lasts like 2 hours, and you have to keep taking more and more. Sometimes it's helpful to switch to Rytari in some cases, where it's designed to be 3 times a day. It's kind of a slow release. It has time release beads, and it's a time release formulation. The downside is you usually have to take like 3 or 4 at a time. So even though it's 3 times a day, if you're taking 4 at a time, you still get 12 capsules a day. So, you know, at the end of the day, you're not necessarily taking fewer pills, but less frequently and maybe smoother. So for some people, it works great. Some say it doesn't make a difference. You know, it's mixed. That's where you need to talk to your doctor. There's a more recent inhaled levodopa. Has anyone tried it here? I mean, some people say it causes a lot of coughing, and it doesn't last that long. It doesn't last hours. Usually it's more of a rescue. So if you suddenly turn off and freeze up, it's like an inhaled, it kicks in within 10 minutes or so, but usually only lasts like an hour or so. So it's kind of more of a rescue. Well, I mean, I shouldn't ask people's experience unless you're interested to share, but. Not to be nosy or break any privacy, but if anyone has heard anything. So it hasn't been used. I haven't used it that much, to be honest, because it's a little difficult to get. It's mail order pharmacy, so it's expensive. Plus, it's just used in that circumstance. It's not something you take all day long. We haven't used it much here either at all, but there's like a Duopa, or it's an intestinal gel. It's basically you have to have a tube, a feeding tube into into your intestine. And this is like a pump that just continuously puts it in. So the advantage is you're getting a more even dose all day long, but the downside is, of course, there's a tube into your intestine that you have to maintain that can get infected or break down. And honestly, it hasn't been widely received, but they're working on other pumps that go just under the skin, more like, or things similar to insulin pumps, things like that. Then we have these dopamine agonists I mentioned. This rotigotine is the patch, Mirapex and Requip. There's also something called apomorphine, which is technically a dopamine agonist. It's been mainly an injectable. Now they're making it in different forms, like under the tongue. But again, it's more of a rescue treatment. So it's not something you take all day long, but can help you get from one carbidopa dose to the next. And then I mentioned briefly the COMT inhibitors. Again, it prevents the dopamine from getting chewed up, so you have more of it around. The main one we use is entacapone or Comtan. Some of you may be on it. Tolcapone, not too many people use. It was the first one, but caused a fair amount of liver problems, so it's not really used. More recently, okay. So the Comtan, it helps that your dose lasts longer, supposedly, and a little smoother, longer and smoother. So increases your good on or good period. So the entacapone is designed, every time you take one of these, you take one of these with it. So it could be a few times a day. And I didn't mention there's a combined medicine called Stalevo that has this plus this, so you're not taking both. Recently, they came out with this opicapone, which is once a day version. So you don't have to take it multiple times a day. You just take it once. It's supposed to be 24-hour. I've had some experience with it. It seems pretty good. I don't know if anyone's tried it. Then we talked about the Azilect and Rasagiline. There are older medicines that can be used for tremor, like Artane, trihexyphenidyl, or something called Cogentin or Benztropine. These don't really help balance and walking and stiffness. Mainly, it helps shaking or tremor. The problem is, honestly, as you get older, it's hard to tolerate these because it can affect memory, it can affect vision, you get blurred vision, dry mouth, constipation, etc. So by the time I mention all those side effects, everyone's like, not for me. You know? So it's generally at least above 70, it's not really recommended. I mentioned this amantadine to increase dopamine, helps tremor and involuntary movements. This is a new one that's just coming on the market, istradefylline. So just in summary, again, the dopamine releases this chemical, and all these different drugs we talked about act in different ways. The dopamine agonist at the target, dopamine to release, etc. Okay, so we're always interested in seeing, is there something that can protect the nerve cell or neuroprotection? It's a big buzzword these days. Of course, we want to protect the brain and the nerve cells and hopefully slow down the condition. So they've looked at different things like the Azilect, this rasagiline or selegiline. People have looked at vitamin C or E, hasn't really been proven. Coenzyme Q10 had a lot of excitement initially, but then more studies showed it didn't really convincingly slow down the condition, disease. So they've looked at things, even estrogen. I know this is kind of technical, like other chemical blockers, etc. Okay. Are you with me? I know it's a lot of okie doke. Let me just go over it one by one. So amantadine, again, it was studied to be an antivirus drug. I've been interested, although we didn't do a study, to know, if people take this, do they have less chance of getting viruses like COVID? We don't know for sure, but could be. It's kind of a mild or pretty weak antivirus drug, to be honest. But I have had patients that said, since I've taken this, I never get colds anymore. So maybe it does have some benefit. But it helps tremor and helps the dyskinesia. Everyone's familiar with dyskinesia, I think. The involuntary movements, usually in the hands or head and face. So it increases dopamine by both releasing more dopamine. So more of the dopamine gets released. It prevents it from being taken back into the nerve cell. So it keeps it floating around and gets to the target, etc. And it may block another chemical that is harmful to the brain. So that could be good. The main side effects, it can sometimes affect your blood pressure regulation or even cause hallucinations or memory trouble at higher doses. The main side effect sometimes is ankle swelling. And there's new formulations. So different companies now are making, instead of twice a day version, once a day version. To be perfectly honest, I'm not sure if the once a day is worth the extra expense and all that versus twice. It's not like you're cutting from 6 pills to 1. It's just going from like 2 to 1, basically. So there's things like GoCovery, for example, but they're hard to get. You have to go through special pharmacies, etc. So these other enzyme inhibitors that we talked about, again, they're trying to see if it's maybe neuroprotective. The one that's been around for decades was called selegiline, typically once a day. There's a newer one that just came out on the market called safinamide. I don't know if anyone's on it, which I'll jump to. Safinamide is called Xadago. Anyone on that? Or tried it? So it's similar to the older ones, but it has a little different action. They say, well, it also maybe blocks this glutamate, which is not so good for you. I mean, it's a little different, but you've probably heard of like monosodium glutamate, that they put in different foods. Some people get headaches and so on. So glutamate in general in the brain can be cause some harm or kind of blockage of function. So they're saying maybe this inhibits glutamate, but honestly, I haven't used it that much to know if it's helpful, but that's a new one. Okay. I'm going to try to explain this. It's difficult to understand, so we'll just go quickly. But the question was, when they did ASELECT studies, the studies showed that people that did start the medicine earlier than a different group that started later seemed to do better like 2 years down the road than the ones who waited, suggesting maybe it can help slow down the progression of disease. So in other words, if I start this medicine today and you start it in 6 months, 2 years from now, they found that I'm going to be maybe doing a little better, less tremor, less stiffness. But the question is, am I doing better just because it helps my symptoms so I look better and function better, or is it actually changing the disease? To make a long story short, they seem to think maybe it's modifying the disease a little bit. The government wasn't convinced that they could call it neuroprotective. There's a lot of controversy. So the best we can say is maybe it slows down disease slightly, but that's not to say everyone should go out and take it. It's not so convincing that we recommend it to everybody, but it does improve on period and maybe help symptoms about 15%, 20%. So it doesn't help symptoms dramatically, but the thought is, in theory, it might slow down progression. Okay. So many of you, as you probably know, the levodopa, it's been around since the 60s. So it's been around a long time. It's still the gold standard. The main side effects can be nausea, some drop in blood pressure when you stand up, feeling tired. Over years, you might get some fluctuations where it doesn't last as long, or you get involuntary movements. Sometimes compulsive behavior like gambling even, or excessive eating. Some people have this dopamine dysregulation syndrome where you almost feel like you have a craving for more and more dopamine. Can be a problem because you may not actually need so much, but the feeling is there like you're needed. It's almost like addiction. So there's ways to help block the nausea. So if you have nausea, there's some medications. If the blood pressure goes low, there's some treatments like we'll mention ahead. Or to block hallucinations, Seroquel, sometimes used, or quetiapine, but can cause some drowsiness. The new one that's on the market is called Nuplazid or pimavanserin, Nuplazid. You've probably seen commercials, and the commercials are kind of bothersome to some individuals because it talks about the frequency of seeing shadows or even perceptions and hallucinations. Maybe the most effective one is clozapine, but it's strong and can suppress your bone marrow, can kind of shut down your bone marrow production. So it's hard to use. You have to get blood tests almost every couple weeks. So the concern with levodopa, and even some more recent studies are suggesting that, we shouldn't be scared of using levodopa. And maybe since it's the most effective, some would argue it's still the best one to use even early on. But the concern is over years and worsening disease. It's not felt necessarily that the medicine stops working or you get immune, but as the condition can change over time, the benefit is not as robust with the levodopa. So let me show you, so the dyskinesias we talked about. So this hopefully is a helpful slide. So this is like early in your Parkinson's journey. This is more moderate symptoms or more advanced symptoms. So early, moderate, advanced. So just focus on this part. This is the good zone from here to here. Between these two dots or the hyphens. So so in early stages, you take the levodopa, and most of your time you're in this beneficial, happy zone where the medicine's working. Below here is when the medicine's not working. You're off. You're very stiff, slow, shaky, etc. Above this is when you start getting too much movement and the dyskinesia. So you can see this is an ideal situation. Good benefit, no dyskinesia, no involuntary movements, and no off. So as you progress though over years, you can see this person takes a while, it takes almost an hour before it kicks in. It kicks in, but they're really in the good zone for maybe like an hour or two, during which at the peak, they may have too much movement, the dyskinesia. And then after this point, after 2-3 hours, they shut down again. So you're not getting as much good time. It takes a while to kick in, a lot of time off, and some dyskinesia. And excuse me. This person, I think this should be shaded. You can see this person takes a long time to kick in. There's very little good time before they have the dyskinesia and then off. This is another way to look at it. It gets after a while where it's just these like a yo-yo up and down. Takes a while to kick in. You're moving too much, off, on, off, on, off. So what happens if this develops, that's when you try maybe things like the Rytari, or to make it fewer doses, or you start talking about deep brain stimulation surgery, which generally can cut down the medicines like 50-70%. And it's extremely effective, the DBS, to help with tremor and dyskinesia in particular. Or you may want to cut down on the levodopa and try the dopamine agonists. I mean, there's a lot of different techniques. So we'll switch gears to the dopamine agonist. I use mainly the patch these days, to be honest. It's once a day. It's somewhat easier to use as long as it doesn't cause a rash or other symptoms. The nice thing, it actually tends to last longer than levodopa. So that's why I mentioned they're coming in once a day versions, both the Mirapex, Requip, Nupro patch. I won't get into this too much, just to show that they last a lot of hours in the body. The patch, again, is once a day, may provide smoother delivery, but it can cause irritation at the site. And some people do have these tendencies to gamble or excessively eat. You have to be careful, especially with the gambling. It can really drain a lot of financial resources if it's not detected or caught. But there are a lot of side effects, like with anything. And as you get older, sometimes the side effects are more with these agonists than with carbidopa, levodopa. So again, nausea, vomiting, headache, sometimes a drop in blood pressure, drowsiness. Rarely people kind of like suddenly fall asleep talking or driving. You can have confusion, hallucinations, paranoia. This impulse control problem, like gambling, I said, it could be binge eating, getting a lot of hobbies. We spoke briefly about apomorphine. It's been more of an injection recently, but now they have different types where you can even take it nasally. Rectally may not be too desired by many, but the point is you can get it a lot of different ways. The main side effect is nausea, vomiting, or drop in blood pressure. So usually a person would come to the clinic and we try it out over a course of a day where you pre-treat with some medicine to prevent nausea so you don't get severe upset stomach. So the question is, when do you start treatment? And basically the bottom line is it's not one size fits all. It basically depends on your lifestyle, depends on the person, what kind of work you do. I mean, it's different from someone who's, which I say, I was going to say an airline pilot or something, but maybe that wouldn't be wise. But it depends on your level of activity and needs. So if someone's very young and you're going to be on treatment for a long time, so there's increased risk of long-term complications, increased maybe job-related responsibilities possibly. So you may think about starting a milder dopamine agonist and saving the levodopa for later. While perhaps later in life, we tend to use much more of the levodopa. It's well tolerated. less side effects, more effective. And as you get older, there's less of this concern. I mean, there still is, but less of a concern of long-term dyskinetic movements or loss of function of the levodopa. So you can think of it if it's not impairing your function at all, it's reasonable not to take any medicine. I have a lot of people I see who don't want to take medicine, and it's reasonable, especially if they're functioning well. Some people also try, I'm sure you want to ask about herbal remedies. For example, mainly in India, there's some supplement called Mucuna purins, which is kind of has dopamine in it. So some people feel it really helps them without medications, called Mucuna, M-U-C-U-N-A. Fava beans has some dopamine, but the problem is you have to eat like a bucket of fava beans. It's a lot of fava beans to really get much dopamine. If you have mild symptoms, you might try the amantadine I mentioned. If it's mostly tremor, things like amantadine, you can treat depression, anxiety-related symptoms. I don't think we need to get into this too much. Basically we start the levodopa slow and increase slowly over time. But what are some of the signs of wearing off? So it's not just getting slower or stiffer. So there's the motor symptoms like the bradykinesia, getting slower. But as the medicine wears off, you'll notice, as you well know, difficulty getting out of a chair, sometimes twisting, dystonic movements, involuntary twisting, imbalance or cramping. Sometimes can be nausea or trouble breathing even, or pain, stiffness, tremor, or weakness. And some of the non-motor symptoms with the off, it's not only just a motor, it's abdominal discomfort, anxiety, sometimes sweats, drooling, trouble breathing. Your mind may seem kind of cloudy, facial flushing, or even irritability. I mentioned pain, numbness, etc. So it can be a whole host of things as the medicine is tapering off. Finally, leave some time. I'm a big proponent of physical therapy, speech therapy, occupational. I'm sure many of you have benefited from speech therapy. Some are in the Parkinson'S and other groups, Speak Out Loud, etc. And so that's very helpful. Physical and occupational are very important. Things like rock steady boxing, I'm a big fan of. John knows a lot about those things. So for freezing, there's a lot of ways they can train a person to try to prevent or minimize freezing, like different auditory and vision cues. For falling and imbalance, physical therapy can be very helpful. I mentioned vivid dreams or hallucinations. There's we try to cut down on medicine as much as we can, of course, or alter medicines or some of these medications to try to prevent hallucinations I mentioned. Depression is very common. Up to even 90% of people describe some degree of depression. So there are some medicines, or seeing a psychologist can be helpful, even sometimes psychiatry. Different treatments for anxiety, restless legs is fairly common with Parkinson's. Usually low doses of these dopamine agonists, including the patch, can be very helpful. I mean, this is a whole nother area, but memory difficulties could be even more. Here they say up to 30%. Sometimes it's just mild age-related forgetfulness, but it can become more prominent. So there's some testing we usually do, including MRI of the brain. Just a little plug. I'm blessed here because we have some renowned sleep specialists. So not uncommonly, I do refer to sleep, especially if people have difficulty falling asleep, staying asleep, snoring, sleep apnea, or to try to capture these vivid dreams to really see if a person is acting their dreams out, punching, fighting. So there's different things to do to try to help that. Often it's important to see a urologist because Parkinson's can affect the bladder function, or you may have other causes. There's sexual dysfunction, nausea, excess sweating, we talked about. One of the very, very challenging things is if you develop this orthostatic hypotension, or, going from lying to sitting to standing, drops in blood pressure, could be a big problem where people get lightheaded. They can even, as you know, pass out. Sometimes it's just a lot of shoulder or heaviness. So we try to work with the cardiologist or primary to reduce any medicines they take to reduce blood pressure. Other medicines we try to cut down. Practical things like increasing salt, like salt tablets even. Occasionally, sometimes compression stockings help. And there's some oral medication, including a new one, droxidopa, to try to balance. But it's very challenging because you don't want the blood pressure to go too high. And some people have a roller coaster situation where it goes too high. They take a medicine that goes too low, and it's just very hard to regulate. But it's important to sleep at a 30-degree angle at night so the blood pressure doesn't go too high when you're sleeping. So things that can respond to non-medication include, balance, mobility, posture, gait, speech, very important, speech and swallowing evaluations. Hydration, I mentioned the sleep clinic, etc. And then there's a number of surgical treatments, just briefly, as you likely well know. The main one these days is deep brain stimulation with a pacemaker under the skin. So we do those.
Damien's calling you.
I'm sorry? Oh, somebody said. As you may have received flyers in the mail also, up in Hackensack.
You gotta sit there. Do you hear me, Tom? Tom, don't you get up?
Up at the main hospital there in Hackensack, they're starting to do focused beam ultrasound. We don't do that here, so I can't speak with authority, but it's approved for a procedure just on one side of the brain to help, and it's really designed to help tremor. So if somebody has severe tremor from Parkinson's or essential tremor, it's a technique externally. It doesn't go in the brain, but you kind of burn a little area in the brain through these focused ultrasound beams to really help tremor. But we don't know yet if it's helpful for stiffness, slowness, other symptoms. So certainly if you have essential tremor with severe tremor on one side, something to think about, but the verdict's still out on the Parkinson world. So these are other, so the importance is a team approach, family, caregivers, the medical team, various therapists, social work, community support groups. And you know well about all the different support systems and Parkinson Foundation, et cetera. Okay. All right, that's it. I went a little long. Any questions that I can try to answer?
I have one.
Yeah.
I was diagnosed this July with Parkinson's, and I don't have tremors, but my balance is really off. I fall backwards, not forwards, backwards. And I was wondering, I'm on the carbidopa, levodopa 25-100. And is there anything else that I can do?
So we can talk offline, I guess, about personal things, but I mean, about your situation. But so a lot of times in that scenario, we really advocate a lot of the therapies, like the physical therapy, like LSVT, big, as well as Rocksteady has been quite helpful for many, or they feel like it has been. I mean, medication may need to be possibly increased, although I know you want to maintain a balance of keeping the lowest effective dose and not escalating too high.
Yeah, I don't have tremors. Right. So my main concern is the balance.
Yeah, so probably medicine-wise, the one you're on tends to be the most effective. But have you done any physical therapy or those?
Yes, I have. Yes.
Was it helpful or not too much?
Yeah, it helps, but I guess I just have to watch it. I mean, going backwards is really a problem for me.
I admit, yeah, that's a difficult particular symptom.
Me too.
Yeah, the falling backwards, we don't have as much, the medicines are not as effective as some other symptoms. And honestly, not to be negative, but sometimes it's felt the deep brain stimulation, while helpful for that kind of backwards retropulsion, sometimes it's not as helpful as we'd like. In addition,
What about frozen gait?
yeah, so freezing of gait also, it's kind of the same medicines we've discussed, but also techniques through the OT and PT and Rocksteady. They have other techniques to help freezing. Some people use like the U-step walker with the laser or other
I do have that,
visual cues.
but that doesn't work for me anymore. I have to find new tricks.
Sorry, I'm trying to find you on the videos. I'm seeing just a few at a time. Which
Can
are
I
you?
say something?
Tom? Yes.
I'm Megan. I'm a speech pathologist at one of our outpatient rehabs, and I'm a loud certified therapist. And I don't know how long ago you completed your big therapy, but we always reinforce the big therapist and the voice therapist here that it's just as important to keep moving with that same level of effort as it is to take those medications on that dosage system. So I don't know how diligent you are about sticking to your exercise program, but I do think that can make a big difference with things like balance or those kind of freezing episodes. So if you, as diligent as you are with your medication scheduling, I think if we can get yourselves, especially in the winter, moving a little bit more, maybe you'll notice some improvements. I do think the medications are very important, but we have to keep you moving with the same effort you were using in therapy.
Mhm.
Great, thank you.
That's the hard part. Often people feel like during the therapy or while they're in it, they feel well, but even the same day when they go home, it starts to dwindle, and it's hard to maintain, certainly with the lockdown these days.
I think if you have a phone or have the option to ask your therapist to even video you in therapy, that can be a good reinforcement tool for you to look at down the road and realize maybe I can be doing things differently, or maybe I need to go back for more of a tune-up session or a refresher evaluation, just like you do with the physicians.
Mhm. Okay.
Has anyone found Rocksteady to be helpful, or any comments on that?
I actually do, I guess I should show my visuals, but anyway, I do cardio and kickboxing in the mornings, every morning for 45 minutes. And I really feel this well-being, sense of well-being. And I also find that it helps me with the balance.
I confess the freezing of gait is a challenging one that is really, it's one of the ones that don't, we wish responded more, more excitedly and more efficiently than it does, but because the medicines help to a degree, but not fully, for sure.
What about if you have surgery, anesthesiologist? Is it good to go under if you have Parkinson's or not?
I mean, in and of itself, it's okay, but with Parkinson's, the recovery times tend to take a little longer than without Parkinson's. So
You don't lose your memory?
You should, I mean, there's still, sometimes it depends on the degree and length of anesthesia, but in theory, you shouldn't if all goes well, unless you get, as long as blood pressure, oxygenation, everything is maintained. It's not really the anesthesia in and of itself, but if for some reason you get like hypoxia,
Okay. All right, thanks.
should be okay. But I mean, if you need surgery, I wouldn't delay or not do it, because of that concern.
Okay.
I could be a little biased because my dad was an anesthesiologist. So. I always hesitate. No, I'm kidding.
I have a question for Mike. How important is using water to dilute all those medication doesn't make any toxins if you don't drink enough?
Sorry, were you asking me or somebody else?
Yes, doctor. I'm asking you.
Say it again, please.
How much important is drinking, using water, taking those medications? So
Yeah, it is important. I mean, we advocate usually at least 6 to 8 cups of water a day, not just because of medicine related, but in general because of, there's tends to be with Parkinson's tendency to drop in blood pressure or dysfunction of this autonomic nervous system, which regulates blood pressure and so on. So it's important to keep hydrated in general, but to avoid blood pressure being lower and causing lightheadedness or falling or passing out for those reasons. Sometimes regulating the blood pressure, and it can help other symptoms in particular.
If a person starts, can I ask if a person starts to take medicine, will they always have to take it, or could they consider it as a temporary solution?
No, you can come off of them. It tends to be a little more challenging with the Synuclein because the body does get used to it, and sometimes it can be a bit challenging, but it's not like you cannot come off of it. It tends to be a little easier with the MAOB inhibitors or agonists, but we tend to taper things slowly. There can be withdrawal symptoms if you abruptly stop things, so it's important not to abruptly stop something.
Thank you.
I'm having trouble sleeping, and I understand that melatonin is useful, but I understand also that it has an MAOB negative effect. Can you talk about that?
Good question. Melatonin has mixed results, but it can be of some benefit. It is also helpful sometimes, as I mentioned, to possibly do a sleep study if you need to kind of really quantify things better. As far as the MAO, I confess I have to look into that a little more. I can't give you a definite answer on the melatonin with MAO. I'm not aware of it.
I was told by one doctor that it was an issue, and then told by another doctor that it was not, so I'm curious.
Oh, I'm sorry. Do you mean like interacting with MAOB?
Yeah.
Oh, not that it affects the enzyme itself. I'm sorry.
My understanding was that it affected the medication, that there was an interaction between the two medications, between melatonin and the other medications that I was taking. I think that would be the carbidopa, levodopa.
In general, to my knowledge, it doesn't really affect the carbidopa or the agonist. The thing with the MAOB inhibitors, they do have a lot of interactions. You'll see on the package insert, that they say to be careful with even things like certain muscle relaxants, with certain antidepressants. There could be an interaction like a serotonin syndrome, or certain cough medicines like dextromethorphan. So there are a lot of interactions with the Dazelect and Selegiline. To my knowledge, melatonin's okay, but let me confirm that.
Wear masks.
Hi, Dr. Hanna, it's Wilson. I know you mentioned methadone, right? Being an antiviral drug. Well, I haven't had cold since you prescribed it to me years ago. I remember when was the last time I had a cold. So she's doing something, I guess, good.
You haven't had a cold in years.
Yep. I don't remember I don't remember the last time I had a cold, actually.
Good. That's good to hear.
What medicine are you taking for that?
Methadone.
What?
Methadone, I mentioned, had some antivirus benefit. Maybe it's your wonderful guitar playing.
Could be.
Okay, well, thank you for your time.
Thank you very much.
Doctor.
Thank you.
Thank you,
Bye.
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 Thank you, Dr. Hanna.
Thank you, Dr. Hanna.
Good to see you.
Thank
Have a
you.
good day.
Hey, Donna.
Hi.
That was terrific.
Yeah.
Did you take a new patient, Dr. Hanna?
I don't know. I don't know. I see him. He's very good.
He took Larry recently. Larry's a relatively new patient
Okay.
of Dr. Hanna's.
It's worth a shot to give him a call if you want to switch.
Right.
He's very good and he takes the time with you. I mean, if he sets an hour for your visit, he's there every bit of the hour. He doesn't cut you short or anything. So I like him a lot. He and Dr. Rossi.
Right. I go to Rossi, but he's only here on Thursdays.
I know. It's hard to get an appointment with
I
him,
know,
but
yep.
I think he's I think the first doctor I saw there. Actually, Allie suggested I see him. And then I think he suggested I see Dr. Hanna. So they're both very good.
Right.
And like I said, they take the time with you. They don't just say, okay, no, if you ask him a question and he doesn't know the answer, he'll look it up for you right then and there.
His focus is in the room.
Yes, exactly. Yep.
I had Dr. Hanna when I first was diagnosed with Parkinson's disease, and it was very good, very nice. Now that I have PSP, I'm being treated by another doctor, Robert Wood Johnson, who's also very good also. But and that woman that was talking is, I don't know, I forgot her name, falling backwards. That's one of the typical things of PSP. You fall backwards, not fall. I don't know who she was. She likes to hear that.
Okay.
I
That
fall
was
backwards, walk backwards.
I'm
yeah, I
sorry,
tend
what?
to
I have frozen gait also. My walking is not that good.
well, I tend to stumble backwards. I could just be standing there and not moving, and all of a sudden I just start to go backwards. And if I try to lean forward and pick something up, I topple. I got to be very careful.
Wow.
Yeah.
Wow.
Yep. But I have not fallen yet. Thank goodness.
Thank God.
Don't say yet.
True. Hope to keep
Your
it that
guardian
way.
angel. Your guardian angel will help you.
Okay. I have a few of them up there.
Donna, how did your bathroom come out? Did you get it finished?
I have a couple little finishing touches to do, but otherwise, yes.
Oh, it's great.
It was very nice. It was very good. It was very nice.
Thank you.
That
It was tough. I'm sorry, Lisa, did you say something?
Yeah, I did. Hold on.
No. You just muted yourself. You have to unmute. There you go.
Okay, you can hear me?
Yes.
Yeah, I think the biggest thing with me is stiffness, and stiffness is just terrible.
Yeah.
Well, I'll tell you what, physical therapy will help. I went back about 2.5, 3 weeks ago because of the heavy head. My head was literally too heavy for my shoulders. I couldn't keep it up. I would sit like this at the table, or just put my hand under my chin so I could at least, talk to people or just be comfortable. And I have, knock wood, in the 2.5, 3 weeks I'm going to physical therapy, hasn't happened again.
Who's your physical therapist?
Jennifer Lazaro.
Oh,
And she
she's
actually has
good.
a student with her who is
She's very
phenomenal.
good.
Yes. Yep.
I had her one time.
Helps too.
What's that?
Rock steady boxing
Oh
helps.
yeah. I
Yeah.
was doing that in the beginning for a while. That's how I started at JFK. And I had to stop because I have hip fractures.
Oh.
So, yeah. Keep trying to knock me down, but I'm stubborn.
That's right. You can't give
Good.
up.
No.
Right.
Good for
Don't
you.
give up.
No. Nope. Yep.
All
Because
right,
I don't
everybody,
give.
I gotta go, but it's been great talk.
Okay,
Great
David.
Yeah,
guys.
thank
David.
Bye.
Thank
Yeah.
you. Good night.
Take
Safe
care. Have a
home.
good
Thanks,
weekend.
David.
Stay warm.
I'm actually a 25-year ovarian cancer survivor
Wow.
Wow.
of one of the more aggressive types of ovarian cancer. I was 38 years old when I was diagnosed,
Oh my
which
God.
is unheard of as well. So like I said,
Very fortunate and lucky.
yes, that man upstairs is really testing me.
Yep.
I keep telling him, I know you don't give us any more than we can handle. Well, the shoulders are getting very heavy, very heavy. They're ready to, but I'm never give up.
Right.
Because once you feel you can't, when you get tired and everything and you're just done, you got to keep pushing. Because 90% of the battle is a positive attitude.
Right.
And if you can
Very
have that,
true.
yeah,
Very
if you
true,
can have
Donna.
that, yep.
Thanks for reminding us of that.
It's very important. It's the number one thing you should think about every day when you get up. What am I going to do today? And I'm going to be positive. Now, I'm not saying that every day I am. I've had a couple of days in the last week or so that have been really bad, but you have to push through them.
Right.
And that's when I take out the Wii and I put the training baseball on and I try to hit home runs. I take out the boxing and think, I like the boxing on the Wii as well. And the tennis. So.
Everybody have a good night and a
Yeah.
good
Good
weekend.
night.
You as well.
I'm leaving too.
Bye.
Nice to
Good
see you
night.
again, guys.
All
Good
right,
night.
take
Can help
care.
that
Good
too.
night.
Night.
Donna, ice cream can help that too.
What's that?
Ice cream can help that too.
Oh,
sometimes.
there's 3 gallons in my freezer. Don't think I don't know that.
Mint chocolate chip.
I like the moose tracks with the
Yeah.
peanut butter
That's
in them and anything with caramel in it, and the Friendly's creamsicle, like the orange creamsicle ice cream. Oh,
Does it really taste like a creamsicle?
yes, it does.
Wow.
Yes, it does. Yep,
I grew up on those in Brooklyn.
yep. And I have a box, well, actually 2 boxes right now of waffle cones in the cabinet.
Have a
And
fudge
chocolate peanut butter. That's my favorite.
Yeah.
The drumsticks.
Yes, I've been tempted to buy those too, but
They're the same thing as a waffle cone.
yeah, yep.
You need
But
another
Good.
freezer.
I
Yeah.
have one downstairs.
Anyone
I
ever
have a-
tried Dibs? DIBS? Little round balls that are covered in chocolate.
Yeah. Yeah. A long time ago. They still
Any
have
good?
it though.
Oh, they're fabulous. They're
Are they?
fabulous. They're wonderful. And it's a small box and it's one serving is the whole box.
Oh,
So
They
I
had
like
them in
that
vending
too.
machines. They had
It's
them in vending
amazing.
machines years ago, I think.
Take care, Steve. It's amazing the little things that really we enjoy. Yeah, crave. Yep.
Take
I'm
care.
on a kick with black
Bye,
licorice
Steve.
or Good and Plenty's.
Ooh. Oh, wow. Black licorice.
Yes.
Yum.
Yep. So my cabinet is full of goodies. My mother doesn't help either when she comes up. You don't have any chocolate? No, Mom, when we go out, I'll get you some chocolate. Well, she leaves it here. So what am I going to do? I can't let it go bad. I take a
No.
little
That's when you
piece.
call us all over to your house. We'll
Okay.
take care of everything.
Yeah. Well, right now I'm taking my Christmas decorations down, which I hate.
Yeah.
I hate taking them down. It's so cold and, just depressing. But next year will be here before you know it.
When do you put yours up? Thanksgiving weekend?
I start, yeah. When
Right.
my nephew, before he leaves my house on Thanksgiving, he takes all my buckets up. I have about the big, like I guess they're 30-gallon Rubbermaid buckets. I probably have about 5 or 6 of them that I use everything in there.
Wow.
I decorate from the time you walk in my door through my downstairs, my dining room, my kitchen, my living room. And I also have stuff for the 3 bedrooms upstairs, which I don't do very much anymore. But yeah.
Well, so
This
it's
is-
Santa's Workshop Part 2.
Here is a picture of the wool unit I have in my living room. It's a
Oh,
built-in.
wow.
And
Wow.
everything on those shelves that I had on before the Christmas stuff, they go in the back of the shelf because it's very deep. And even did my outside. I do this all the time.
Nice.
This year I did that all by myself, put it up and took them down. I have an old broomstick that there was a little notch in the one side already. So I just made it a little deeper and that's how I get up and down. 'Cause I can't go on ladders very high.
Right.
And in front of my house, in that area under my kitchen window, it's stones. So
Oh.
there's no way I'm,
Right.
especially with the balance issues.
Of course not.
Yeah, well, I used to take the week off after Thanksgiving, and that's when I did all my decorating, my baking. Took me a little longer this year, but
What I find sad is that people with real trees, the day after Christmas, they throw them out already.
I know.
And you still got the whole week between Christmas and New Year's.
I have a couple of people I know, they put it up Thanksgiving night and they take it down Christmas night.
Wow.
Yeah. No, I
Whenever
like,
the music on the radio, though, they start Thanksgiving and the day after Christmas is gone.
yeah, Christmas Day, like at 12 o'clock, they stop it.
Yeah.
Yeah, but
You got to stay away from those kind of people.
yes, we need the music. We need a lot of music.
True.
Yeah.
My sister, when we used to go Black Friday shopping, my one sister and I, my middle sister, she passed away, but we used to blast the radio on our way at 3 o'clock in the morning and just have a great time.
That's good.
Yeah. But now with the phones, you can hook them up and, get anything you want.
Right.
So don't have to listen to the radio anymore. But yep. So anybody have any big plans for the weekend?
We have bubble lights on our tree.
Nice.
The big old ones.
Lights on my
You know-
tree have to blink.
Oh, wow.
That's nice. Yep. And
Cool.
every all my windows and my railings here, everything lights. The
Wow.
more lights, the better. Yep. My
Well,
sister
it must have a high electric bill, but so what? It's worth it.
Exactly. I don't care. My sister used to say, all right, we're going to the Griswolds today for dinner. Yeah. I used to do a lot more outside too in the front. But last 2 years, it was just, I just, put them under my window.
Right.
So I used to put the lights strung along my front way on each side of the sidewalk and down my driveway. My neighbor said it looks like a landing pad. There was a little they're bulb lights, but I get them at Big Lots. Looks like the bulb lights you used to put on the tree.
Screwing
And they're on-
kind, like C4, C7 or whatever.
Yeah. Yep. And I used to put those outside too. But these other ones are a lot easier. They're plastic. And they have their own little sticks, just put them in the ground. And because the one year I put the